You are watching the latest edition of the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, the latest advancements in pain management. If you or a loved one are experiencing chronic pain, my advice, stick around for the latest edition of the Wellness Hour.
The Wellness Hour, an in-depth discussion with today's top physicians and medical leaders. And now, your host, Randy Alvarez.
You are watching the latest edition of the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, what's new in pain management? My first guest is Dr. Robert Odell. Dr. Odell is representing Knoxville's leader in pain management, Back Pain Institute and Lensgraf Medical Center. Dr. Odell, welcome to the program.
Thank you for having me, Randy.
Before we get into today's topic, tell us about the Institute, for those that don't know about it.
We treat patients with all kinds of pain, back pain, sciatica, foot pain, neck pain, thoracic pain, carpal tunnel syndrome. These are some of the leading causes of pain in this country, and we use a variety of mechanisms depending on where the patient's pain generator is, what the cause of the pain is.
You're using, I guess, medications, chiropractic, injection therapy. What are the different approaches? I mean, what all do you have there? Because you say you're completely comprehensive. What does that mean?
Well, the patient is evaluated, and then we decide what the best way of treating the patient is. If you have a hammer, everything looks like a nail. And with all due respect to my surgical colleagues, and they tell many, many patients that they can't help them because surgery isn't indicated. Okay. At our clinic, everybody can be treated. Somebody, let's say, that has generalized osteoarthritis, one of the only mechanisms of treatment might be appropriate medication management. But in many cases, the primary care physicians aren't really prepared to do optimal medication management because some of these medications have some side effects. Okay. At the medical center, we can do that. In addition, back pain, which is the leading cause of pain in this country, they have lumbar decompression, or VAX-D, which is probably one of the best things that come along this century for treating low back pain, in my opinion.
Spinal decompression.
That's exactly right. It's just incredible.
Now, you're a medical doctor, and yes, you believe that this works.
Absolutely.
We've talked off camera.
Not only that, is there's literature behind it. It's just absolutely terrific, and there's no risk. Neck pain can be treated in some conservative ways, as well as carpal tunnel. They have a cold laser, which can be used absolutely safely. You don't have to even begin to think about going under the knife. A lot of I've done anesthesia for carpal tunnel surgery, and sometimes it doesn't work, and the patients are left with the wrong problem. With a worse problem, I mean, and it's really kind of sad when most of these things can be treated more conservatively and more safely.
Now, we've talked off camera. We talked about the pain patients. There's a lot of people in Knoxville, surrounding cities, that you say are undertreated, or they're in pain and they don't have to be.
There's a lot of people that are being treated by their primary care physicians, and there are some better ways of treating them with different medications. There's just no way that the primary care physician can understand and can know about these new treatments because there's just too much knowledge in both pain medicine and in their own specialties. None of us can keep up with everything. I mean, this is all you do there. Yeah, exactly.
I mean, is your recommendation always go to a specialist when it comes to pain? Well, that seems like an obvious one, but not everybody does.
If I had a heart problem, I certainly wouldn't go to an orthopedic surgeon. I mean, I'd go to a cardiologist, and I think this is the same thing. The thing that makes pain interesting is that pain medicine really has only started in the early 90s. And so it's only emerging right now as a specialty. They don't have a 4-year track residency yet, like they do orthopedic surgery, in cardiology, internal medicine. Yet. They probably will, in the next 10 or 15 years. And so pain medicine has been kind of just out there, managed by different specialties: anesthesiology, neurology, physical medicine, rehabilitation, and so forth. One thing we have in our clinic is a board-certified neurologist who directs the care of all the patients. It's so important that.
What does that mean to the patient, by the way, having a neurologist there?
You can get a diagnosis. Many neurologists that are not interventional, all they do is diagnose a lot of these fancy diseases. But our neurologist actually treats, and he utilizes all the different modalities that we have available at the clinic, including physical therapy, chiropractic, the cold laser, ordering lumbar decompression, interventional pain management with injections, some of which he does himself. Okay. So it's you really need a multifaceted or an approach that utilizes many different modalities. You can't do it one-dimensionally these days. Pain is too complicated.
So not all is being done then. I mean, many patients that are watching this they think everything's being done, but it's not. Or maybe there's more options for them.
You couldn't have said it any better. You couldn't have said it any better. I mean, we need specialists, more specialists in pain medicine in this country right now.
Okay.
And I tell you, Knoxville is well served by the Lensgraf Medical Center and Back Pain Institute, because they have got it already. They're a leader in that area, and they were one of the first to be able to integrate pain medicine the way it should be.
How does somebody get to see a specialist like you, or some of the doctors, the neurologists at Lensgraf?
They don't need a referral from their primary care in most cases. They just go and make an appointment.
They could call directly.
They can, and they can be seen within a day or so.
Backing up, and I want to go back to that point. You say that many patients are undertreated. What do you mean by that?
Well, there's several aspects to this. The first one is medication-wise. Those patients that are taking pain medications may be taking the wrong ones. For example, Vicodin is a short-acting medicine. There's much longer-acting medications. Now, they can be used in
Are there
place of
people
Vicodin.
that come in and they're on medications and you see them and say,
Well, they need to be on different medications, at least temporarily, until perhaps we can reduce their pain. Now, the second aspect of this is the fact that there are so many more treatment modalities that are available now that were not available in the early 90s when pain medicine started as a discipline.
Okay.
For example, lumbar decompression, which we talked about. One other example, necks. Many people would get epidural steroids for neck pain. 60% of all neck pain is due to the facet syndrome. Without going into technical details, it's associated with whiplash. These are the structures in the back of the neck and have nothing to do with the spinal cord, which the epidural steroids treat. So all those treatments, maybe the patient might get better for a few days or maybe a few weeks, but generally speaking, they needed something entirely different. And this is what I'm talking about as far as the advances. Some of the other interventional techniques that we're using are...
Define interventional. What is interventional?
Interventional means you use a needle and local anesthetic and with or without steroids in conjunction with other treatments. In the clinic, we have 2 C-arms. A C-arm is something that the doctor can use to look and see exactly where the needle is going, so it's placed in exactly the proper position and for maximum safety and efficacy.
Who's a candidate for one of these facet injections?
Anybody with low back pain, it's been shown that in many cases patients have multiple sources. The lumbar decompression, which we talked about before, treats the disc or the front part of the back. The posterior or the rear elements, the elements in the back, are the facets, and that can be about a 15 to 30% cause of low back pain in the patient population. And many patients have both a disc and a facet cause. So we have found that the injection of the facets, or the nerves to the facets, are called the medial branches, can help improve the patients that are being treated, for example, under VAX-T. And of course, some people only need the facet injections alone.
So combination therapy with facet injections and this spinal decompression.
You hit the nail on the head, Randy, because people who have back pain or any type of pain, most of the time there's not just one single cause. It's multifaceted and it needs to be treated several different ways. In some cases there's one cause, we make the diagnosis and we treat it. But in terms of the back is a very, very complex structure. And it's widely written that many people with low back pain have more than one source.
Are these people getting better, or are you just putting a Band-Aid on the situation? What's happening?
Well, in some cases you do have to put a Band-Aid on, and you want to use the smallest Band-Aid you can. But in the case of lumbar decompression in conjunction with these blocks, I'm convinced that many of these patients are, and I shouldn't use the word cured, but are maximally benefited because of the physiology of the way the decompression works and the way the injections work.
Starting with spinal decompression, who's a candidate, and who's an ideal candidate, I should say?
Well, any patient with low back pain, either with or without sciatica, they cannot have hardware or they can have had a fusion but no hardware. Pretty much anybody with pain, this is a chronic nature, is a good candidate for VAX-T.
So is it traction, this decompression? What is it?
It's a very fancy type of traction, and I don't want to go into the technicalities, but it's done so that the back muscles are fooled. When the back is pulled apart, the back muscles do not pull back, so that there's a true vacuum created. The stuff from the canal, from the marrow, water, nutrients, and oxygen is sucked in. It's called a positive diffusion gradient scientifically, and actually it heals the disc, which is I shouldn't say the word, but it's a cure in many cases. People who have had VAX-T really do not have to come back.
You've had patients that have been, I guess, chronic pain patients that have used VAX-T, this spinal decompression, and their pain goes away or lessened. What is it?
Absolutely.
Absolutely what?
Many people go to zero.
Is that right?
That's the beauty of it. Yes, this is definitely not a Band-Aid. I mean, it is probably the best treatment to come along for low back pain in years, and the other thing is it's very safe.
Were you skeptical when you first saw this spinal decompression?
Absolutely, but I've seen the results that are just fabulous.
Okay, now for people just tuning in, we're talking about advances in pain management. We're talking with Dr. Odell. He's a medical doctor specializing in pain management. We're talking about VaxD right now, but you do everything. I mean, you guys do injections. You have neurologists on staff. Before we leave this topic of the spinal decompression, the patients, I mean, what's the treatment like?
Well, for the lumbar decompression, they come in once a day for about 20 days, occasionally more than 20 treatments if needed, and they're hooked up to a harness. The harness actually will pull them for about 30 minutes. It's a 1 minute on, 1 minute off cycle.
Does it hurt?
No, it does not. They wear loose-fitting clothing. There's no undressing. There's no invasion. It's all completely non-invasive, and it's the patients might experience a little bit of discomfort for the first couple times, but generally speaking,
is this done over 2 months, 3 months?
Done over 1 month.
Over 1 month.
Usually 20 treatments, 5 days a week for 4 weeks.
How long does the treatment take?
About 30 minutes.
30 minutes. Mm-hmm. Moving on to this cold laser. Who's a candidate for that? Or how are you using it, I should say?
It's excellent for people with all sorts of pain. Carpal tunnel, it's outstanding for. It's used in conjunction with decompression for the low back, for neck pain. Really any part of the body where there might be inflammation, the cold laser can be used.
So the laser goes on the area?
Yes.
And what's happening? I mean, what's the mechanism?
Well, it's a pulsed laser, so there's no heat generation. The cell isn't damaged. The energy gets into the cell somehow, and I'm not a physicist, but it gets into the cell and it's released inside the cell, decreasing inflammation and allowing the body to heal itself. It's quite remarkable.
Have you had great results with that?
Absolutely. It's very, very effective, especially for carpal tunnel syndrome, which is a very widespread problem, as you know. The transverse carpal ligament goes over the median nerve and it compresses it, and it's all about inflammation. That's really one place where the laser shines. No pun intended.
Now you utilize physical therapy right there on site. How so?
Well, you can treat the patient's pain and get rid of it, but if you don't get the patient moving and functioning again, then everything may be for naught. These patients are going to go out, they're going to be picking their grandkids up, they're going to be picking their kids up, they're going to be doing things, and we want them to be doing these in as pain-free a state as possible. You need to restore function for the complete healing process, and that's one of the key elements of the treatment at the medical center.
If there's a mistake in the world of pain management nationwide, what is it?
Many patients, for example, might get epidural steroids and then the doctor just sends them on without any rehabilitation. Reflex sympathetic dystrophy, you do a sympathetic block on the arm and you don't do the physical therapy. It's just absolutely key to get it moving, and that departs a certain degree of healing in addition to treating the pain itself. Restoring the function is the best thing you can do.
So not enough aftercare is what you're saying?
In many cases, yeah. In many cases, you'll actually have patients who may have a pain score that's very close to when they came in some clinics, but if their function is improved, that's considered a modicum of success. In our case, I would say, especially with low back pain, that's not the case because our pain scores are much lower or close to zero. But the function is just all important. It cannot be overemphasized. And it's the tremendous physical therapy they have that allows these advances to be realized.
Okay, what advice can you give a pain? We're going to take a quick break, but what advice could you give a chronic pain patient that's watching this? They're living with their pain. Maybe they don't think all is being done. Maybe they haven't seen their doctor in a couple of years. What do you say to them?
Well, I think that if they haven't been evaluated in a while, it would be real good to come into the clinic to be evaluated because of all the advances. There's probably a lot more things that can be done, especially if they haven't been seen. They may have also been seen perhaps by non-pain management providers. And I think that would be another outstanding reason to come in to see us in the clinic, to know that they're getting the full array of what's out there for treating pain, because I think, again, as you said, pain is so much undertreated, and a lot of it because people just don't know.
Okay. Are there people that are afraid of, because you know, medications, I mean, for the right candidate, are there some people that could be out of pain if they weren't so afraid of medications?
A lot of people could be out of pain if they weren't so afraid of medications. I think a lot of people could be out of pain if they weren't afraid of the needles, and the needles are small that we use. Yeah, and the needles are small that we use, and they're done very carefully. It's probably easier than going to the dentist. But yes, I mean, there are risks associated with all these things, and we certainly want to start with that which is the least risky, obviously, and then progress to the more invasive treatments as needed. In many cases, we don't have to advance that far, and we can actually help the patient with the lower level modalities, and we can do it safely.
Now, this program, the Wellness Hour, airs nationwide, and I've interviewed hundreds and hundreds of medical doctors, and the inside scoop, it seems, that I pick up on is nobody likes the pain patients. You like the pain patient. Why did you choose this area of medicine?
Well, there's so much that we can do to help them. Again, it's the number one reason why patients seek medical care. And there's been so much learned in the last 15 years in pain. The thing is exploding. The amount of information is exploding. The number of procedures that we can do. I'm an anesthesiologist. I enjoy doing procedures. I'll be upfront with you.
Okay.
But in conjunction with the physical therapy that we offer, with the counseling, with the chiropractic, with the other modalities, I enjoy functioning and practicing in an environment where the total patient is treated, and that's the case at the clinic.
Now, you work in and around other pain centers.
Yes.
How does this compare?
It's first rate, absolutely first rate. From the organization, the efficiency, the way that it is run by Dr. Lensgraf and his staff is just first rate. The integration of all the different modalities, it's efficient, it's organized.
Would you say they're more aggressive than most centers that you've seen?
You know, I like the use of the word aggressive, but I want to define the word in this sense. They don't run in and do the most invasive thing first. I would define aggressive as efficient and thorough.
Okay.
A diagnosis is made, the appropriate ladder approach, the least invasive up to the most invasive is done, and then the patient is sent away, is discharged in the best possible manner that I believe can be achieved anywhere in the area, short of surgery.
Now, you say you guys treat pain as an emergency.
If patient is in pain, they can come and see someone in the clinic within a day or so. There's no reason for somebody to continue to be in pain. Maybe their medications are too short acting, as I mentioned before.
So there are people that are out there that are taking medications that are just outdated medications.
Yes.
Okay.
Exactly. But
how does that happen, by the way?
Well,
they're just not working close enough with their doctor?
Yeah, there's so many newer medications out there. I mean, I have trouble keeping up with the medications outside of my field, even blood pressure medications by mouth. I'm an anesthesiologist. I have a couple meds I use IV in surgery to treat people. But there's all kinds of
longer acting. I mean, if you had to say what's new in medications, it's longer acting.
Absolutely, yes. Now, let's take an example of a patient whose back goes out. They're antalgic. They're walking like an old man. They very could benefit from an epidural steroid injection.
Okay.
Right within a day or so. That is one indication for the epidural steroid injection right away to get rid of the inflammation. And a lot of people just don't know that, and they'll sit around for a couple of weeks and suffer needlessly.
If we had to say your specialty, I mean, is it spine pain you guys are seeing there?
It's not just spine pain, it's all kinds of pain. As I said, carpal tunnel and arthritis, things like that. But spine pain really comprises one of the largest groups of patients because epidemiologically, it's one of the leading causes of pain in this and really in the world. So most of the people de facto have spine pain, but we treat people in any type of pain. And of course, remember, you're being seen by a neurologist. The patient's being seen by a neurologist who...
What does that do? Just allow for better diagnosis?
Oh, absolutely. These guys know fancy stuff that I've never even heard of.
So better diagnosis obviously is better treatment.
Yes. I
mean, is that the tricky part, finding the pain generator? I'm sorry to interrupt here.
Most patients are misdiagnosed.
So things are missed.
You spoke a few minutes ago about if you're out there and you're in pain and would you come in? And I forgot to mention, many people may have the wrong diagnosis, and they need to come in to have it looked at again by somebody that does this full time.
Okay, then give me a typical wrong diagnosis or missed diagnosis.
Well,
that happens.
In low back pain, it used to be 85% of the time because the MRI, for example, shows bulging discs. Okay, it might be facet pain. The bulging disc might have nothing to do with it. In other words, the MRI is falsely positive. That happens all the time.
So they're treating X-rays or MRIs rather than the patient?
Yes.
I mean, help me understand what's going on.
Exactly. exactly.
Okay.
Somebody else, let's say, that has multi-level spondylosis or degeneration, they're not sure what can be done. Maybe the diagnosis is correct, but for example, the decompression will treat all the levels, and the injections can treat many of the levels of the facets that might be pain generators. That may not be a matter of diagnosis, but a matter of the extent of the disease. Yes, all this disease can be treated.
Do you have patients that were scheduled for back surgery or were told that they need surgery and that it was avoided because of what you guys do there?
Yeah, Bruce Wilkerson, who was a star at University of Tennessee and went on to play pro football, actually had back pain that shortened his NFL career. He told us that had he known about VAX-D, he might have actually played for 2 more years.
Now, VAX-D is spinal decompression.
It is, yes.
Okay.
Now, I also want to add that he was scheduled for surgery and it was canceled. Okay. That doesn't get any.
So you're
more
big on
dramatic.
spinal decompression. A lot of medical doctors, and I ask them questions, many don't know that much about it, or they poo-poo it, or they say, I don't believe it. It's too simplistic. What do you say? What do you say to those doctors that watch? I mean, they watch the show. What do you say to them about spinal decompression?
I'd like to say take the time to learn about it and look at the literature, because the literature for VAX-D is solid, including a randomized clinical trial and a trial that's going to come up pretty soon that was done in Pennsylvania, where about 450 patients, about 90% of them got better with lumbar decompression.
Okay, what are the results there? I mean, with your patient population, as far as them getting better, noticeable improvement with this?
89% get better. Better is defined as 50% or more reduction in pain, and as we talked about before, improved function, which is the Oswestry low back index, and some other measures are utilized. Scientifically.
But most of these people are getting injection therapy, maybe a combination of medication therapy combined?
Very often the medications can be eliminated as the patient gets better. And if they're taking narcotics, they're watched very carefully by the neurologist or the physician's assistant, and they're tapered, so there's no problems with habituation. And with
Is that your goal, by the way, to taper people off medication? I talk to pain patients that are on medications. Of course, they don't want to be on medications, but they say there's no other way. Is that your goal, though, to taper them off?
Absolutely. Most of our patients don't want to be on pain medications, and the tapering is very often successful. And a lot of times they can go from a narcotic to an NSAID, something like that, or even down to acetaminophen or something, or an occasional pain medication.
Okay. Now we're going to take another quick break. We come back, more about the process. Take me through the process. Somebody with low back pain, neck pain, chronic pain. They go to your center, what they can expect on day one. You're watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. We're discussing back pain and neck pain, or any type of chronic pain, here with Dr. Odell. We'll be right back. You're watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. We're discussing chronic pain today and what's new with Dr. Odell. Okay. Now we've talked about injection therapy, medication, the spinal decompression. What are some of the other things you're doing to eliminate pain?
One very big area is in balance. Medicare made the decision several years ago to fund the testing and the treatment of balance. The reason for this is falls are one of the leading causes of death in older people.
Okay.
And I don't mean immediate death, hitting your head. I mean if you break a hip, in the first year, the mortality rate is 20%. If these can be prevented, not only is it humane, but it's a tremendous savings of resources. These balance centers, the balance center at the clinic is top notch.
So the patients that come in for one thing, they're part of this program. They're put through this system.
What if a patient falls and maybe injures their knee and comes in, and maybe we find out that in the workup that perhaps they were dizzy before they fell? We'll certainly rule out something cardiac, something serious like that, and the neurologist knows how to do that. Then what we do is test their balance, and that can also be treated. Many times it can be treated very, very simply, and look at the savings and look at the morbidity and mortality that's prevented. This is one of the best thing that Medicare has ever done.
It also helps them get back to function. Is that right?
Absolutely.
Are these classes? Are they one-on-one? Is it more like physical therapy?
It's physical therapy for the labyrinthal system, really. It's a device, a series of devices where they're actually trained, and they can reverse some of the pathology, and then basically the patients will not be afraid of falling anymore. They'll be more confident in their ability to walk around. Again, depending on what the other comorbidities are. But it's been a very, very effective program, and it's probably saved untold number of falls.
Tell me me about the team of doctors you have there.
Well, at the clinic, we have board-certified neurologists, as I mentioned. We have 2 mid-level providers, a physician's assistant, nurse practitioner. We have chiropractors. We have physical therapists. And then, of course, the support staff. So there's really a whole wide variety of personnel that are able to treat the patient, that are available, and in many, many different ways. And it's just this number, this wide variety of people, that increases the efficiency of the clinic in terms of being able to handle a wide variety of problems in a very efficient way.
Now, it's not common that I have a medical doctor on the show that's specializing in pain, that's utilizing chiropractic. And we've talked, you say that they go together. Because chiropractic's become more mainstream. I mean, 10 years ago when we started the show, it was considered alternative. Now it's becoming mainstream. I mean, physicians are seeing chiropractors. I see a chiropractor for prevention reasons. What are your thoughts there?
Well, a lot of pain management doctors look at muscles as things you stick needles through. And if you just do the injection and you don't follow up with any function, then many times the patient's going to suffer, as I mentioned before. Now, the other thing that chiropractors add is a modicum of absolute diagnosis, because they know the musculoskeletal system so well. They also assist the physical therapy. It all goes hand in hand. They're kind of a brother of the physical therapist. And again, it's the whole idea of the team. A lot of these problems the patients have had for a long time, they won't go away in a few minutes. You need a complex organization that has multiple types of therapy to get them better, to give the patient the best shot at returning to normal function and with a low pain as possible.
Final message: patient, they're in pain, chronic pain. They've never visited your center. They're living with their pain.
Give us a call. Chances are that they have not been exposed to the multiple modalities that we have, and I believe there's a good chance that we could help them. Just give us a call.
Okay, great. I want to thank you for coming on the show. Very interesting.
Thanks, Randy. Appreciate
You've been watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. If you would like to see this again online, visit wellnesshour.com. For now, I wish you good health. There you go.